This is the CT scan in both the coronal and the sagittal sections demonstrating a right-sided skull-base defect at the level of cribriform plate. As you can see, we navigate in the sagittal sections and the coronal section. We are able to see small sac-like protrusion and a defect in the central anterior skull base at roughly the junction of anterior and posterior ethmoids. This patient has had a history of right-sided spontaneous CSF Rhinorrhea. This has been confirmed on the CT, and later on, as we will see on the MRI imaging, one can see a small meningocele that is herniating out of the anterior skull base defect at the level of cribriform plate, which also happens to be the most common site of skull base defect. What you see now is a heavily T2 weighted MRI image, which also shows you the CSF in a white color. And now you see how one can see the meningeal sac and a slight tracking down of CSF on the right side skull base defect at the junction of anterior and posterior ethmoids, which was seen earlier. Now, the starting part of surgery is not being shown here. One can see we have completed and a broad ethmoidectomy, sphenoidotomy, and the resection of the middle turbinate. The resection of middle turbinate gives us a wide access to the skull base, the cribriform plate, and the middle turbinate resection also provides us a large amount of mucosa of the middle turbinate, which we can harvest as a final closing layer in these patients. Normally, we prefer a multi-layer closure in these patients. As you see here, this is a skull base defect that we have located. The sac of meninges you can see very well. These may or may not leak actively at the time of surgery, but they are still prone to meningitis, so they are always surgical treatment. We can see the lamina exposed laterally on the right side, the septum medially. And now what we are doing is, before we proceed further, we are just coagulating this sac. And this is very important, foremost for taking care of any vascularity that these small meningeal sacs may contain. The last thing you want to do is create an hemorrhage that goes and tracks intradurally, and to avoid that, all meningeal sacs have to be nicely coagulated before they can be resected and repaired. You can see the sphenoid sinus here in the front, the maxillary sinus, and we always see that we have not taken down the sphenoid sinus so below as to injure the septal artery. Though we are not reconstructing using the septal flap here, but we always prefer to keep the septal flap in place so as to keep it as a option should there be contingencies later in these patients, or there would be recurrent leaks or leaks at some other area. So we always make a point to preserve them. The septal flaps, now we are using, you can see the defect region. Now we are using a coblator. This is a Prosize Max font which we are using not just to coagulate on the actual meningocele, but we also use the ablation mode to demucosalize and denude, ablate a lot of mucosa of the cribriform plate, the anterior ethmoid, and the residual septum superiorly, because this is the way we prepare our graft bed for our fascia to settle completely. So we always believe in exposing and denuding a large surface area for our grafts to well set. Grafts will never settle down or adhere to mucosa. One needs to give the graft, whatever that be, bare bone, bare, and I repeat, flat bone as much as possible. So whatever septations one can remove, one must remove either through cutting instruments or through drills. You can see the axilla here, the erstwhile attachment of the middle turbinate area. Now you see how the superior part of the septum has been, septal mucosa has been taken down. Again, we are avoiding going too below to avoid injuring the septal artery. You can see how the anterior ethmoidal roof is now being coagulated broadly with the ablation mode on the coblator. And this is in turn to achieve hemostasis, and most importantly to achieve clear bare bone for our grafts to adhere. This is the roof of the posterior ethmoid and the sphenoid, which is now being ablated. So one must not shy away from ablating a reasonable amount of mucosa in all these regions. And once you have done that and you have coagulated the meningocele, you can very well ablate it as well, so as to be able to locate and isolate the defect very nicely for it to be repaired. Our goal here is to use 3 layers, which is the fat, the fascia, and the mucosa as a free mucosal graft from the harvested middle turbinate. Hemostasis is very important, as you see here. So once again, once we have ablated, we have to remove any bone chips or any excess mucosa, excess loose-lying bone. We don't want to push bone deep inside the cranial cavity. So this has to be cleaned and minutely. Now you see, for most part, we are doing good here. A lot of bone and is now exposed. One can see the anterior ethmoidal artery on the left side, anterior to the defect. Now, once we have done that, now we're using a broad elevator to palpate the defect, most importantly, to isolate the bony boundaries. This seems to be right size. Sometimes if it is too small, we need to enlarge it with punches because an extremely small defect cannot be closed. But here the defect size is reasonably okay to be closed. And the rest of the bony septations on the ethmoids, the attachment of the middle turbinate can be simply drilled off and smoothened using a diamond burr. So we prefer to use a 4 mm diamond burr for this purpose. It's a fine diamond, not a coarse diamond. We do not want to create any more defects in the skull base. This is merely to polish the bone and smoothen it out for us to prepare a nice flat and bare bone bed for our grafts to adhere. So the graft, normally we use the thigh for the fascia lata. If it is a very small graft, one may also use the temporalis fascia, just like tympanoplasties. But fascia lata is good because it gives you a lot of graft size. It's also thick, and this can be managed quite easily in case one requires certain more amount of graft for a certain patient. Now, this has been seen. Now you see a wide enterostomy here. The sphenoid is clean. You can see a broad septal flap being clean and in place. Should there be a future need for a septal flap onto the same side, that's always our preference, not to use up anything that we don't use. And now we are further bipolar coagulating our residual meninges at the location of the skull base defect, which is now to be closed. And once we have done that, we have to further on use our fat to obliterate this thing. So now, once this has been done, we can see how we want to be very, very generous in our use of the bipolar here. We do not want to keep any residual mucosa buried in this region, because if we do that, then there is a possibility of a future mucocele formation. These are never early complications, these are late complications. And if by a careful surgical technique, they are very well avoidable. So any excess mucosa, loose strands of fibrous tissue, they are best removed, because anything that protrudes too much will obviously affect your overall graft placement. It will not be smooth, the graft will not adhere to the bare bone around the defect, and that will always lead to suboptimal results and a worst case scenario, graft failure. So we prefer to do this, and now you see how we can simply palpate the defect by taking our Mason's elevator, the sharp end of it just between the dura and the bone, to see that we have just slightly undermined, and that's good enough. More undermining is normally required in those situations where we use fascia directly over these defects. But since we are using fat, a broad understanding and recognition of the bone defect is good enough. And you see here how the elevator just goes in a layer between the dura and the bone to acknowledge the defect that we have, over which the fat will be kept. The fat will not be kept here, mind you. The fat has to be inserted with more of it inside than outside. So it is a sort of a tight seal. Over that, we would like to keep a fascia, because we want to be very sure that everything is tightly set and not just loosely lying here. Now, once again, we use a diamond burr to further smoothen out the boundary between the sphenoid plenum and the posterior ethmoidal roof, to be doubly and triply sure that the entire bone is smoothened and well receptive for our fascia lata graft. So this has been done now, and the adjoining part of the superior septum with the sphenoid and the posterior ethmoidal roof is now being drilled. Just smoothen it out barely for adequate graft placement. Last bit of hemostasis to check if there is no bleed, that we need to take care of it before we place our grafts. Some of the team members already have harvested the fat graft and the fascia. The mucosa has been taken off from the middle turbinate. You can see the anterior ethmoidal artery now very well visible. In this particular situation, since our defect was well behind the anterior ethmoidal artery, we did not need to do anything to it. Sometimes if in an anterior based defect, the anterior ethmoidal artery needs to be coagulated and taken down for our bone to be flattened and for us to place a graft nicely and neatly. You can see how the skull base defect has been very adequately isolated, smoothened, and excess tissue removed. And now with this has been done, you know that the exposure part is well taken care of. And now you come to the last and the most important part is actually the graft placement in this situation. A little bit of meticulousness and over denudation of the mucosa around the angles and the superior aspect of lamina papyracea can come handy. This is where we use our navigation probes to once again map and double and triple check the fact that we are right on to the skull base defect as seen on our CT scans and MRI scans on the navigator maps. And once we have done that, our field is now very much set to be grafted. So you see here we're using a fat graft. We obviously take a little bit of an oversized fat, and then what we do is once we insert it nicely and tightly, and if we feel that the fat size is too big or protruding, we can take a fine scissors and trim some part of it while the rest of it is actually inside. We never use a ball probe for insertion because the ball probe will always keep getting the fat out. So we use any sort of a straight flat instrument. It could be our Mason's elevator, it could be an angled elevator. We then never use curettes, and sometimes a simple instrument like a curved Blacksley forceps is very handy. One has to not be rough here, just a gentle but sustained pressure onto the sides gives you a very snug fit of the fat. You see here, the fat has been reasonably snugly fit with a little bit of it protruding outside, which we are now pushing it gently, slowly and steadily using an angled elevator. We never rush this step. We don't want to push the brain too much or contact the actual brain tissue. These patients are normally given anti-epileptics so as to avoid any brain or dural irritation. Now you see how an angled elevator very neatly and nicely pushes the fat just appropriately for our comfort, and any excess fat here and there on the posterior margins can be simply excised using a fine scissors. Now that our fat is well set in the bony defect on the skull base, the next part is basically to put a fascia that is slightly bigger than the fat, over which we will keep a mucosal graft that is slightly bigger than the fascia itself on a layer by layer. So you see, we have a relatively not too big sized fascia lata graft that we are placing onto this region. Mind you, this should not be sitting over the mucosa of the septum. That way it will never adhere. So this has to sit on the bare septal bone or cartilage and the bare bone of the skull base. And once it is nicely set, now at this level we normally use our uh, tissue glue to set the first two layers well over this bone, and over this tissue glue we will eventually be using our free mucosal grafts. And you see, it's very important to not let your fascia graft be rolled up just like you do in tympanoplasty. And now once the facial graft is well set, well placed to our comfort, we use tissue glue over this, and for a straight movement we let it settle down and cool down, over which in the end we cover the entire bare bone that we have made using ablation with a free mucosal graft from the excised middle turbinate. This can be taken from the middle turbinate, from the inferior turbinate. The middle turbinate seems like a natural choice because it offers us a good exposure post resection of middle turbinate, and the entire mucosa, if elevated appropriately and correctly, can lead to a reasonably sized graft for us in all these patients. Now you see, once we use the middle turbinate graft mucosa, almost the entire bone that we ablated is now being very well covered with this free mucosal graft, over which we'll just use a little bit of Surgicel in the end to secure it nicely. And what we have normally seen is that when we use a free mucosal graft over anything that could be fascia or fat, It helps in reepithelialization of the entire surgical site much faster as compared to when we just use only fascia. Only fat, of course, is not to be used because that will be reabsorbed. The fat must never be exposed to the outside environment and air. So any part of fat that we use for skull-based reconstruction has to be covered with either fascia or a few mucosal graft. This completes the end of surgery. A simple pack is placed here for 2 days, and the patient is planned for discharge after that.